We are at the ASH meeting on hematologic malignancies. We're in Chicago, Illinois. And the topic is the future of clinical and translational research in hematologic malignancies. And the person that I'm with is someone who's probably familiar to you, Bob Löwenberg, MD, PhD. He is a professor at Erasmus University in Rotterdam, the Netherlands, but you probably know him more as the editor-in-chief of Blood. And this is a great topic. And I've been working in the field of translational research for a while. What are the things that you're going to be talking about here at this meeting?
So we deal all the time with patients whom we cannot offer effective treatments, right? So the challenge is to change the world. And we have experience with diseases that once were fatal and that we can treat now. So there we have been able to transform a bad disease in a favorable disease. And the challenge ahead of us is how can we expand this so that we advance the treatment to those patients that today have a notoriously tough disease. And this is the topic, and I will discuss several examples of patients that we meet in our clinic and discuss possibilities for how can we tackle the problem.
I mean, because of your position as editor-in-chief of Blood, you know what's coming up, you know a lot of things earlier than most people. It's moving that from translational science to the patient where it gets to be interesting. What can we do to speed that process, to enhance that process?
Yeah, it's a good question. So we have learned a lot about these diseases, lymphoma, leukemias, myelomas. They are much more complex diseases than we had initially thought. We thought if we have a drug, we can, and if it is effective, we can cure the disease. But there are many reasons why these diseases will fool us and escape the treatment. So future strategies should really be based on our current knowledge. So that's one. Second, we should accelerate the process. We are far too slow in developing new treatments. It takes much time. We do huge trials. They take years. But now we are dealing with diseases that are not homogeneous. One disease is not the same as the other. So if Mrs. Mary comes in on Wednesday and Mrs. Jane comes in on Thursday, and initially at first glance it looks like, they have the same disease, we may be fooled. They may have very different diseases, and we may need to treat them very on a personal basis, which is called personalized medicine. Right. So the objective really is to find tricks to tackle these diseases much more effectively with smarter drugs and with combining drugs.
And better understand the immune system so that you're working with the immune system or propping it up when it needs to be.
That's a good point. So what do we need? We need smarter drugs, but we also need smarter therapeutic modalities so that we can tackle the disease from different points. And such a multifaceted approach is more likely to be successful than a simple approach.
Now, in the time that you've been editor-in-chief of Blood, do you still get excited when you see papers? Are there still things that can surprise you after 3 years of doing this?
Yeah, well, I've been in the field for a number of years, and every time you see an advance and you think this is promising, you get excited, I tell you. This is our motivation, to deal with patients with hematologic malignancies. We want to offer them the best perspective, and we are excited when new advances come up that may be of benefit to our patients.
Now, when something new comes along, in the United States, the FDA has been working to try to speed up the process. Over in Europe, I think they've done the same thing. Who's better right now? Is Europe better in getting things moved along the pipeline, or those of us here, the FDA?
So FDA, drug approval in the US, EMA, drug approval in Europe, both should do a better job. I'm not satisfied with either one of them. So it takes too much time.
Yeah.
They still apply the old system of drug approval, but we have to move forward. We have to do studies in small subsets of patients with a particular genotype, particular characteristics, for which we want to in whom we want to test a particular drug, and that requires different study designs. And I will touch upon that in my talk very briefly. But this is a major issue. We need better trials so that we arrive at answers much sooner than we did in the past.
Is big data going to help? I mean, randomized clinical trials, that's the gold standard, but is that one of the ways that can change this?
Yeah, big data is important because we learn more about the disease, and the more we learn, the better we can develop new drugs, the better we can design the trials in such a way that we arrive sooner at conclusions.
Based on the papers that you're reading, the papers that are being submitted, and the ones you're publishing, where are we going in the next 2 to 5 years? What are the topics that you think are going to be key to moving us down this path?
So I think what is really encouraging is the development of smarter drugs that target particular gene lesions, gene mutations, perturbations of the cancer cell, where they are vulnerable, where we can hit them. That's one. Second, we can also modulate the environment in which the tumor grows. And if we do that, for instance, the microenvironment, the niches where these cells need to grow, if we can tackle those, that will be helpful in advancing therapeutic outcome. And third, immunotherapy, to use specific attacks based on immune approaches and tackle the tumor. And why not use these in combination?
Are you excited the next few years?
I think it is more, research is booming. I'm more excited than ever before. And there's a lot of promise ahead of us.
And for a long time, a lot of research was done in the United States, but I've got to say, Europe has been doing some phenomenal research in the last 5 to 10 years at least.
So the perspective is that advancements are made on a global scale. It's not in the US, it's not only in the US, it's not only in Europe, it's not only in Asia, in Japan or in China. It is done everywhere. Communication has, of course, changed. We now do global research in partnerships, and the developments go hand in hand at different continents.
And we will continue learning.
Absolutely.
Well, I think this is wonderful, and thank you very much for your time, because I'm looking forward to the presentation, and I'm looking forward to the next few years.
Okay.
So for ASH Clinical News, I am Rick McGuire.